So right after lunch, of course, it's the best time to talk about managing suicidality. So I hope you can pay attention. Okay. So I think one of the most basic and important skill set you need with providing any mental health care is to understand how to evaluate safety and understand phenomenon such as self-destructive behavior and at the extreme suicidality in the context of the individuals who seek our care. So we approach this in a way that really helps us clarify our thinking, because I believe that one of the things that works best about the evidence-based treatments for BPD is that it gives you a clear framework with which you can make decisions. And what we want to do in GPM is to remind you that you need to think first, and you can rely on your own good training and judgment to determine what to do with these patients. If you can calm yourself down and be active and not reactive. So this is how we talk about suicidality for people who have BPD. We explain to patients that when you experience stressful interactions with someone close to you, that is family or friends, emotions can really get intense. Terrible thoughts may come across your mind, and you can do things without thinking of the consequences, as if to relieve something inside of you. And oftentimes patients will really relate to this. One way to organize the experience of becoming more unstable and approaching problems of self-destructive and suicidal behavior is to use the interpersonal hypersensitivity model. So you'll remember this, is that when people feel connected to someone that's important that they trust, they're feeling more comfortable, but they're still anxious about rejection and a possibility that that person won't be there for them. And the problem with that is that your whole sense of self is invested in the availability of someone else, and that's just doomed to fail, right? So easily they'll feel threatened, and in the threatened state, arousal goes up. And what happens is our ability to think clearly, strategize solutions, and understand the situation coherently and realistically goes down. That's for everyone. For people with BPD, it happens at a lower level of stress. So they perceive that they're under attack, or there's something that's kind of upon them that's too overwhelming. And this produces that threatened state where people become irritable. When you're cornered and wounded, you kind of lash out. That's animal behavior, human behavior. So this kind of irritability and anger is either turned inward as self-harm or turned outward as kind of interpersonal devaluation, blame, hostility. But in that state, the person is still very much invested in interacting, right? So this is actually a very productive moment to understand that anything that happens in this angry, expressive state is actually still okay. So if they're screaming at you and yelling at you or expressing high levels of stress and needing your help and being interested or sensitive to your behavior, that's actually a good sign, because they're still available to intervention and they're still sensitive to how much you can support them. It's in this state that self-injury occurs, and self-injury is pretty broad. It can include overdosing on your medication without suicidal intent. It can include deliberate self-injury to the body. Boys do more self-battery, and girls will do more cutting. But these behaviors are just signs of stress. They're ways that people cope with arousal. And actually, researchers in Germany have found that for people with BPD, when you cut yourself, your stressful arousal goes down. But if you don't have BPD and you cut yourself, your stressful arousal goes up. So there's something neurobiologically different about people with BPD, and in fact, they also found that the connection between the frontal lobe or the frontal limbic cortex and the subcortical kind of arousal centers like the amygdala are reinstated by cutting. So people with BPD do this out of some knowledge that it helps settle them. It's just, the problem is it's self-destructive and not very adaptive. But even more so, it scares and confuses people. So then when people are either devaluing or self-harming or both, they paradoxically push away the very people that they need help from. And that's when they become more dangerously behaviorally discontrolled, because they don't have a kind of anchor in reality, so they have no sense of consequences of their behavior, and they become more paranoid about people. So once they're in this reckless state, it's already a little bit too late to try to intervene and collaborate with them, because they're already feeling alone. And John Gunderson actually wrote a paper in 1996 called the BPD as an intolerance of aloneness. Because you don't have a sense of self, you need others to help organize and contain you. And then this behavior actually creates so much adversity that then you just descend into despair. And this is where people are more seriously suicidal. So if they're disconnected, when they're not supported or grounded in reality, this is when you worry more about actual suicide. There's something kind of adaptive about this, because these are kind of smoke signals that go up in the air, and then people get concerned and they do something about it, whether it's putting them in the hospital, showing more family support, or even calling the police. That reconstitutes social support or even social interaction to get people more connected or even more threatened. That's better than having them despairing. So after explaining this, or just understanding this together with the patient, maybe with their family, you can say, the good news is we can work together to develop new ways of coping with the intense emotion and impulsivity that comes up for you when you're stressed. But we also say, while I can help you to manage these behaviors to diminish their cause, we also need to help you find better social supports, people to help you with those situations. So this actually is a very complicated message, is that we're telling people, you know, it's kind of like in diabetes, when people have polyuria and they become thirsty, we can kind of like deal with those problems superficially, but unless we solve the underlying cause of those symptoms, we're not going to get very far. So we can temporize the situation, but more broadly speaking, what we have to get them to do is stabilize their world psychologically so that it's more realistic and reliable for them. So what you need to know about the tendency towards self-destructive behavior in BPD is really something that comes down to assessing dangerousness. And oftentimes statistics helps orient us to the probability that something's more or less dangerous. Now, this is actually more difficult in adolescents than it is in adults, because adolescents do commit suicide, and they have very little psychiatric history with which you can gauge the probabilities. They're more impulsive, and they're more likely to take risks. So we know in this group, because other causes of death are not that prevalent for adolescents, that suicide is the second leading cause of death. And there's a significant risk for suicide for people with BPD. So some studies, older studies, said that 1 in 10 people with BPD will die by suicide. Then more modern studies followed people with BPD for 20 years. They said actually maybe it's between 3 and 5%. But those studies happened at like Ivy League institutions like Harvard, so it's not the typical patient. And I've had colleagues in social healthcare systems like in Australia, where they look at coroner's reports, and they still estimate closer to 10%. So the rate of suicide in this population is quite significant, but the hard part of managing this clinically is that 9 out of 10 people won't die of suicide. So how do we know which ones are more at risk? Because so many people with BPD will engage in some self-destructive behavior, we have to be a little bit more specific about what are the factors that puts a specific individual at risk. We do know having BPD increases the rate of suicide or the risk of suicide 50-fold over someone who has no psychiatric problems. When someone is young, they don't have a psychiatric history yet, they're starting to build one. And what we've learned from studies of adolescents is that the average time from thinking about self-harming to actually self-harming is about 6 months. And then starting to think about suicide to actually trying to commit suicide can be 6 months to 12 months. And actually, even though self-harming, deliberate self-injury and suicidal attempts are quite different, for adolescents, this tends to evolve over a period of 1 to 2 years if there's not proper intervention. So this is actually much more difficult for clinicians working with young people, because for a lot of people with BPD, or a lot of adolescents, about 50% of people will do it at least once and never do it again. But actually there's 50% who will try to kill themselves more than once, 2 or more times. And every time they try to do so, it escalates risk for another attempt. So it's a dynamic assessment, trying to understand who's at how much risk when. And that's why we get all this training. So while deliberate self-harm, like cutting, self-battery, burning, is not immediately dangerous and may be stabilizing, it also increases ultimate risk for completing suicide. So how does this happen? Suicidologists know that there are many risk factors for increasing risk for completed suicide. There are things that promote suicidality and things that protect individuals from suicidality. A feeling of belongingness, a feeling of not being a burden to others, and fear of personal injury. Those are actually protective factors. And what deliberate self-harm does is it habituates young people to self-injury and harming one's physical body in a way that reduces the barrier to suicide later. So that's something that you have to keep your eye on. But what we do in GPM is we try to evaluate each episode in terms of its level of dangerousness in the moment. And I'll tell you how to do that. The difficult thing about this is that people who are suicidal and are driven to actually do something about it, they actually oftentimes will report that they're ambivalent. There's a part of them that wants to die, and there's a part of them that will regret it later, their attempt. And so those who have BPD that are interpersonally sensitive and they evaluate their self-worth in terms of responses of others, they oftentimes will say, if I'm rescued, if I'm important enough to someone else, then I want to live. But if nobody cares about me and nobody tries to rescue me, then I'd rather be dead. So it is something that we feel a lot of pressure about, because what we do about it actually does make an impact. But even more complicated is that suicidal acts in adolescence are more impulsive than they are later. And people, younger people, have less equipment to understand themselves with. So when you ask teens why they tried to take an overdose or jumped out a window or tried to hang themselves, they just say things like, I just wanted to take pills, so I did it. It doesn't give you much to work with. But you do have to help them understand this over time. So like I just said, adolescent self-injury is a strong predictor of suicide attempts. You know, what will happen for a lot of young people is they'll try it once, it doesn't really work for them. A lot of people will become concerned and preoccupied with them, and then they'll decide it's not worth it. You know, there's something else I can do. It doesn't give me the reward that makes this effective for me. And generally, the kind of attention that's brought to the young person when they've self-harmed, it provides enough relief that people care, and then there's more of a dialogue about what is going on for them. And that, for some cases, are enough. The average age of onset of self-injury is pretty young. I don't know if you know the movie 13. Yeah. So it is really around that time that a lot of experimentation goes on, a lot of decreased supervision. So young people are just trying a lot of things. And it's in that framework that youth will try self-injury, just like they'll try other things. But those with BPD will oftentimes say retrospectively that they started self-injuring maybe even earlier. Like I said, the kind of stressful challenges on them exceed the amount of support or capability they have to deal earlier. And for some youths, especially those with other mental health problems, they may continue this into adulthood because the stress is still ongoing and the increase of skills or capacity or tools to deal with it is not sufficient. So this is something that is contextual for each individual, but it's also biological. Like I said, there are some changes that occur physiologically and neurocognitively that show that those with BPD process these experiences quite differently. So for example, people who have BPD have what we call pain insensitivity. So this is actually pretty interesting because a lot of people with BPD or people who self-harm will say, I want to inflict pain on myself because I'd rather feel physical pain than emotional pain. Or they'll say that I'm numb, so I try to hurt myself to not be dissociated anymore. They'll refer to multiple functions of the activity. But what we do know about pain sensitivity is that those with BPD, when they're compared to people who don't have BPD, and you put painful stimuli like heat, again, the Germans did this. You can have whatever judgment you want about that, but they have very flexible IRBs, I think. But they will apply painful stimulus to those who have BPD, and they don't tend to find it as painful at higher temperatures as people without BPD. But what's interesting is that as their BPD symptoms go down, their pain sensitivity goes up. So there's something that I find that people walk on eggshells around those with BPD, but I generally tell people they're better at dealing with certain kinds of stress than we think. Like painful stimuli is not as painful to them. Interpersonal conflict is not as unusual for them, so they're kind of more habituated to certain stimuli than you might imagine. So this pain insensitivity, that's what I said, contributes to the danger to complete suicide at some point in time. And that's why you want to intervene earlier, because as you decrease the BPD symptoms, their pain sensitivity goes up, and they'll be more responsive to those social experiences they have that help most of us learn. Sometimes you'll meet people with BPD and you'll be confused by how come they don't learn from their mistakes? And it may have differences in how they process pain and other self-experiences. Okay. Now, in young people, in a retrospective study of suicides for people younger than 19, we find that it's greater in countries where there's more poverty. So, in general, the rate of suicide is about 8 per 100,000 youths between the age of 15 to 19. But for those who actually are suicidal earlier on, the risk factors seem to be high family conflict and low parental supervision. So it's not just that the person has had trauma. I think trauma is too non-specific a term to understand the pathogenesis of any outcome of trauma. Trauma increases the risk of most psychiatric problems, not just BPD. But it's really the combination of adversity versus support and supervision. Who's there to make sure the environment of the child and the child's activities are safe and healthy. But as kids enter adolescence, they want more privacy. And my own personal theory of this comes from being a parent, is that when people don't have a very stable sense of self, as teens normally do, they need more physical buffers from people. So when my daughter turned adolescent, she all of a sudden wanted her door closed all the time, you know? And you know the do not disturb signs? She made one, but she misspelled disturb. She was do not disturb. But she needed more space to herself to make up her own mind. Like, my opinion was like, you know, it's suffocating because it's too strong, too clear for someone who doesn't know what they think yet. So the problem is that teens are starting to figure themselves out and they need more space to do it, but they're not necessarily sending social signals to the people who are taking care of them in a way that's going to get the support they need. So this makes it more complicated. So what we say about this is that with just self-injury, deliberate self-injury, not suicide attempts, you can do a number of things. If you look at the Cochrane review of treatments for self-injury, there's only CBT, DBT, and MBT. But this brief CBT for self-harm, I've almost never seen it. Have you ever seen that practiced anywhere? I mean, all of us BPD experts, I've never even had the opportunity to learn brief CBT for self-harm. But that apparently is effective. If you know how to do that may be indicated. But medications will rarely diminish self-harm. It's like treating the polyuria or polydipsia of diabetes without providing some support of insulin insensitivity or lack of insulin production. So there are some key clinical recommendations we make that are just general about self-injury. Is you want to respond with supportive concern. Don't overreact, because it's not immediately dangerous, but it is concerning. You want to put the self-harm as a kind of smoke signal of some other problem that the person is having. Too often we take the self-harm in isolation and try to like get rid of it, but really it's a sign of something else that has to be addressed. But the young person isn't very good at expressing or even knowing themselves what it is. So what we say in GPM is you want to proactively ask about the interpersonal stressors that precipitated the anguish. Teens find their social world stressful. So just getting them to talk about it, you might be able to find out what happened. And then you want to talk to the patient and their family about what self-harm means to the patient and the consequences it has. Families get very scared about this and they just want the self-harm to end. But what we try to instruct families about is that this is a sign that your son or daughter is just distressed and that they need your concern and support. So what's more important than getting rid of the self-harm is getting your son or your daughter to talk to you about it. Because the more they talk to you, the more you know about how to understand their difficulties and what to do if they ask you or let you help. Now, turning to suicidality, we want you to rely on the things you already know works for managing suicidality in any patient who has this problem, regardless of their diagnosis. So there's 10 principles. They're not very complicated. The first of which is to just express concern. It's easy with people who are chronically suicidal to ignore or dismiss it as non-important. But just simply saying what happened You know, getting them to talk to you about it, it helps them process or metabolize what's going on and put it into some sort of clear order. That in and of itself is helpful and may relieve the suicidality just with that. Then you want to assess risk. You want to differentiate non-lethal self-injury from true suicidal intention, and we'll talk a little bit more about that. In general, in psychiatry, there are just these very consistent risk factors across studies. And even though statistical analysis has become much more advanced with much larger databases, even machine learning approaches can only have like about 70% accuracy, which is about the same as the usual risk factors that are included here. So stressful interpersonal events, substance use, increased depression, step downs from a lot of support to less support, like inpatient to outpatient, and access to means, lethal means. Those are things that increase risk for completed suicide across the board. For decreasing risk, showing support, positive interpersonal events, like having people in the hospital tell their family, oh, you know how you thought I was going to college? I actually am not going to college right now. These shameful disclosures may relieve pressure, and if their families don't reject them, that can actually decrease risk. Safety planning is a universal intervention for suicidality. Crisis skills, DBT skills, are not just DBT skills, they're just good, global, generalizable coping skills in the time of intense distress. Low-dose antipsychotics temporarily to relieve or take the edge off the intensity of emotions to help people think. It's not useful if it obliterates thinking. And then, as I said, hospitalization. Temporarily, but not as a solution. So for adolescents, more so than adults, there are also the problems within their social environment. Families have problems. They're usually signs of families with stress, illness, or adversity of their own sorts. So parental abuse, financial problems, unstable employment, and parental substance use disorders. This will make their parents less capable of being supportive when the child needs it. Schools provide a lot of academic stress, especially for people who might have special learning needs. Peers, for those who are adolescent, they're just as out of control and unpredictable in a way, so this can lead to a lot of adversity through bullying or exclusion. And somebody asked me earlier to talk a little bit about the internet and social media. In a way, the kind of social pressures of the internet or the virtual world are worse than those in person, because you can bully someone without anybody knowing or without much consequence, because you can be more anonymous online. And so the self is constructed through these virtual interactions and may be, in fact, more fragile and more prone to insult and injury online. And there's also the problem of contagion or imitation by learning about these behaviors that other people are using. That's more prevalent among adolescents because their personality or their psychic envelope is more porous. They're just more prone to this than adults. And also sleeping problems. It's found in longitudinal research that even in infancy, sleeping problems predict BPD later. And even though insomnia is not a diagnostic criteria, it tends to be pretty common among those who have BPD. It's a sign of difficulty regulating one's sense of arousal to be able to go to sleep. So we also do a safety plan, and there's a certain order of a safety plan universally. It starts with what can you do to cope? You know, things that you can distract yourself with. And this is something that comes from animal behavior. In the study of stress and its outcomes, biologists have found that rodents who can gnaw on wood in the face of stress are more healthy than rodents who have no coping mechanisms for stress. So being able to use distress tolerance or coping strategies to relieve the tension of whatever is stressful to them, that's the first level. Then interacting with others who can be supportive without talking about your suicidality. That's the one thing about people who have BPD, they kind of, some of them tend to need to broadcast to everybody how they feel all the time. And this is something that, you know, younger people do too. So, you know, you have to teach people with BPD that this isn't the only way to get people to pay attention to you and support you. And it's actually better for the relationship if you just ask them out for coffee. But if that doesn't work, then you want to actually talk to someone who you trust about what's going on, maybe a parent, maybe a close friend, and try to get more support that way if the other two things fail. If that fails, then call a hotline or a professional, and if that fails, go to the emergency room. So there's like a kind of protocol that the patient is to go through, and it just takes time. Suicidality, like emotions, come and goes. And it just buys some time in which the patient can be their own agent in solving their emotional problem that feels so intense that they need to try to kill themselves. I'm going to skip the video in the interest of time, but what the video shows is engaging the patient as the person who has to take care of their own safety. People with BPD, because of their lack of self-confidence, they're just quick to give that responsibility to someone else. But we really want to engage them, even if you think they have bad ideas. Like they may say, oh, I'm going to pet my dog when I'm feeling suicidal. And you might think, really, is that going to work? But if they think it works and you show approval, it might work. It's your criticism or doubt or skepticism of it that might get in the way more because they'll be influenced by that. So giving them empowerment to kind of make their own plan, and then if it doesn't work, they come back and then you revise it. Oh, you found out that didn't work because your dog got very nervous around you when you were really irritable. So they may learn from experience that things don't work, and they will try to refine their safety plan over time. You want to identify the interpersonal stressors that got them to become so suicidal, and then address that after their arousal level comes down. And then you anticipate this will happen again, and you encourage them to add to their kind of list of early warning signs of suicidality and enhance their social safety net. What are the kinds of activities that you can manage during that time? And this is actually in our book. So you see the worry signs, the signs that I am getting overwhelmed, urges, physical sensations, then using these distraction strategies like painting or petting my puppy that should have like more than one thing on there. Social situations or people who can help distract me, people I can ask for help, and then people you don't ask. You know, people who don't deal well with stress themselves, and then other resources. So the last thing is making the environment safer, which you do more, you can do this with adults too, but because adolescents are so impulsive, this is more helpful sometimes. So we try to educate people to think first, you know, slow down, allow your arousal level to come down so that your frontal lobe kicks in, and you may need to do different things to get there, like journaling, walking, counting to 10, breathing. These are things that we normalize. I generally tell people with BPD, oh, this is what I do when I'm upset about something. You know, it's normal to try to cool off and think first. Get yourself in a situation you can think. Writing pros and cons, the black and white sides of things that can help regulate and instate the frontal lobe. And just like tapping in and turning the awareness inward, that can also start to regulate the arousal level for young people. Tips, this is a DBT thing, but it's not just DBT. changing one's temperature, hot or cold showers, intense exercising, breathing, yoga, lavender, whatever it might be, distraction, watching. I found that patients with BPD like really scary movies, like that I would never want to watch. They like those kinds of things because it takes your attention away. They can also use anti-dissociative skills, and one thing that is really helpful for people who are very distress prone and crisis prone is to give them a portable safety kit. You'll ask them to use these things together. So when I do exposure therapy for people who have had severe trauma, they have to carry around very potent coping kits. They have things like Tabasco, lemon sometimes, things that have strong sensations to them so that it can kind of center someone. So it's kind of like the same changing one intensity with another thing, like self-harm, but it's not as self-injurious, that helps people in those times. And if that doesn't work, you say, okay, let's try to kind of get you more connected. And you want to understand for the young person, what does that mean for them? So in this cartoon, the son says to his mother, I'm not coming for dinner, didn't you read my blog? They have different ways of communicating. Like my daughter, she never answers the phone. I say to her, I called you 10 times. She's like, why can't you just text me? And so you want to understand their best modes of communication and help them by adjusting to the way that they want to communicate. So if none of this works, you ask them, would it help to ask your parents for help? They can offer support, especially if we tell them how to do it, because what's intuitive for them may actually not be helpful to you, so we can work on that. Would it help to interact with someone else? What helps the most to take your mind off things? Get them to be active in thinking about them. And would it be useful to contact me or not? Think about it. So I generally ask people, like, it's not that you can't ask me for help, but do you want your safety plan to hinge on whether or not I have my cell phone with me? Or whether I'm giving a lecture and I can't answer the phone? Do you want your safety to depend on the likes of me? And John Gunderson, when he made this treatment, he never answered his cell phone. I don't think he even knew how to use it. So, you know, a lot of DBT therapists, actually DBT was developed when there was no cell phone. So you had to call someone's landline and they had to be standing there in order to answer your phone call. So that kind of availability was never meant to be what it is today with cell phones. Okay. And the most important thing is involving the patient in their own rescue. So we say from this cartoon, we're encouraging people to become involved in their own rescue. So actually, I heard from a lifeguard, a professional lifeguard, that you're supposed to not intervene until someone stops moving when they're drowning. And I was like, wow, that sounds risky. But actually, when they're actively trying to combat the drowning, they have a better chance of helping themselves than you do. They might bring you both under. So you want to give them enough space to kind of start to engage in their own safety plan. But when they, you know, it's not like you're just going to stare at them, but it's that you want to give them a chance. And I often teach patients, you want to ask people verbally for the help that you want them to give you, rather than acting in a way that can be interpreted in a number of senses. And even in hospitalization, we say to people, I'm willing to hospitalize you despite my concern that it will not be helpful. It's a Band-Aid. So you don't want to get into a control struggle, but you express a conflict. I would do this because I fear that if I don't, you'll feel unheard and you'll become more suicidal. Am I right about that? You check with them. We would both be better off if we can find an alternative to managing this, right? And actually, the more someone develops a life, the more they feel this way. But if they don't have a life, they would rather go to the hospital. So that's why getting a life is really important. So when they do get hospitalized, you want to work with the team on the inside of that as much as possible to help them understand the patient and what will help and what won't. This will decrease unnecessary medications and lengthy hospitalizations. But what you can use the hospital for is some containment while you're working out a plan. When you don't feel like you can interact collaboratively enough to help a constructive path become more obvious. You want to sometimes evaluate the treatment and consider changes. Sometimes when someone is so distressed, that's the worst time to try to change anything, even if it's warranted. So you can use the containment to change medications and change therapies at times, or change the diagnosis. This is also another time that the social support system can be calm enough to think about what's going on and maybe change some of the things they do and learn from you. You want to address situational stressors. John Gunderson, in the beginning of the longitudinal study that he was the principal investigator of, CLIPS, he found that there were sudden, sustained remissions for about 25% of patients. And this happened in 6 months of follow-up. And it was usually some situational change. They got out of a bad relationship, or they changed something in their life that made them feel better. You also want to develop a plan afterwards so that when they return to the scene of the stress, they'll have a different way of approaching it. And you also want to broker difficult disclosures, like I've been using drugs or alcohol, or I'm in an abusive relationship, or I haven't been going to school, or something that they feel like they're already struggling too much. They can't possibly do have a conversation about something so difficult. So in the absence of intensive treatments for BPD, you may need to hospitalize someone just to temporize the situation. I'm going to skip this. This is kind of from the United States, but if you actually diagnose BPD, it gets you a higher rate of reimbursement from the insurance companies. So more importantly, though, it actually focuses on the problem. So the main intervention, once you have everything else situated, is to really understand what happens. We call this a chain analysis, but that's a fancy term for just understanding understanding the events that led to the suicidal action. Assume that something happened in their relational world, and try to help them think about what they could do differently. And a lot of people worry that we're blaming the patient when we indicate that there's something that could have gone better, but it's really to empower them, because the best thing that they can control is their own behavior more than they can control other people's reactions. And the most important thing is that as a clinician, you want to avoid giving in to countertransference urges to be heroic. When these patients are really connected, they're kind of intoxicatingly rewarding. They idealize you, and you want to be the person that can solve all their problems because it makes you feel like you're being effective. Who doesn't want that? But the danger is that when we all fall into this trap of feeling too much responsibility, that starts to kind of decrease the patient's level of responsibility or control. So the most dangerous thing you can do is pretend to be omniscient or omnipotent. So the last thing I'll talk about is contracting for safety. Do people do that here? No. Okay, so I'll skip this. You're ahead of us in terms of your intelligence. Better education here. And you want to understand this in the context. So when you talk to the patient about how they're becoming suicidal in the treatment, you just see it as part of the illness, but you also see it as a sign that what we're doing is not sufficiently working. And you don't want to take it personally, but you're just saying, okay, well, I'm supposed to be helping you with this, so there's something we can do better here. What are we missing? And then you want to also talk to your colleagues about it, because we're all prone to subjective blind spots. And sometimes just talking to a neutral party who's not as emotionally invested can help you realize things that you're not seeing or not dealing with. And we also want you to kind of implicate or involve the families, because at the end of the day, they're the people who are there, not you. And if you can enlist their support, they can be good partners in the project of trying to manage safety, even if they're, the best they can do is not make it worse. Okay, so this is like a modern problem, but also a universal problem that, you know, you want to get them to get into agreements and contracts with you about how things work realistically. So you don't want to be too heavy-handed and too obsessional, but you also don't want to be too liberal and inattentive. So you want to give a young person increasing amounts of responsibility and negotiating power without the necessity of being threatening as a bargaining chip. Okay, so with a young person, you know, this says, under no circumstances will you be out after 8 p.m. That's a rest assured recipe for the young person not paying attention to what you have to say, and they'll just check it off and just move on. But you want to make time to listen. That's one of the most difficult parts of all of this, is that it takes more time to negotiate, talk about, and then follow through on things. That's the difficulty. And young people, because of their brain development, will not always play the tape forward in the way that you might think of it as a clinician or a parent. And you want to teach them how to ask for what they need and gain credibility to get it. So a lot of patients will say, I just want my parents off my back. And I'll just say, okay, that's a good idea. That's normal for a person of your age. How can you get them to believe you more? How can you increase your credibility? Yelling at them and threatening them into taking their car keys and then crashing their cars, obviously not going to work again. So you just point to reality to help them be able to make sense of life. Now, lastly, with family conflict, family involvement, you want to get families to cool down the temperature at home. Parents get into fights when there's a lot of pressure in the family system. You want them to alleviate the pressure on the family system through a lot of different things that we'll talk about, but you want to try to help them understand that their fearful, angry responses, which are normal, are just getting in the way of them achieving their goal, which is to regulate the situation. So you want to support them, but just tell them, okay, there are better ways you can do this. Be sympathetic. Their own difficulties, stress level, challenges, and self-esteem problems. As a parent, when your kids are having this many problems, you feel shame or insecurity, and you want to empower them and make them feel like, okay, this happens. People don't get a handbook on how to manage their adolescence with BPD, but you can learn, and you support them. But what they must do is get lethal means out of the way. If, you know, in the US, guns are a big problem. You want to always ask and advise them to keep those things locked and reduce access to medication and substances. And the parents will have their own coping plan. I'm not going to get into this, but it's in the book that they will need their own strategies to be able to think first and be most helpful in those times. And then after a crisis occurs, you follow up. And you insist on this, because actually for a lot of people who have BPD, the suicidality or the self-harm relieves their stress level, and then they don't want to talk about it again. But you want to insist on it, because that's your job. That's your role. So you follow up, complete the chain analysis, actively interpret what happened, emphasize that they are the ones that are in charge of their safety, and they have to think of a reasonable safety plan that can improve. And you help them not only get relieved of the suicidal episode, but also reintegrate more confidently into their social environment. That's more regulating than any set of skills. Because when you go somewhere for trade, schools, apprenticeship, jobs, community like service, like churches or whatever spiritual community, it gives you a time and place to be and a set of social rules and expectations that help regulate people. I think I'm going to skip this liability thing. You don't have the problems of liability here probably as much. Okay, so in the US, we're very obsessed with getting sued. So the last part is about that, but you don't have that problem here because you're better. Okay, so I will end here and we'll move on to the next section.